All right. Good afternoon, ladies and gentlemen. I hope you had a nice week, an happy weekend. Today we'll be talking about neonatal jaundice, just like you have recommended that we discuss that. So, and then I will take you through a brief story about neonatal jaundice. It's quite a very nice one. I hope that after this one, we will now talk about kernicterus, that is bilirubin-induced neurologic dysfunction, bind, or in other words, also called acute and chronic bilirubin encephalopathy. So, but before we get to complications, so let's talk about what neonatal jaundice is about. So I will introduce it, talk briefly about bilirubin metabolism, the etiology of hyperbilirubinemia. Is my video on? Can you see my face?
No, we can see your screen.
Okay. So let me, all right.
Yeah, we can see your face now. We can see your face now.
It's okay. So like I was saying, I will use this outline like I've listed here. So the complications, I'll just talk briefly about it and then we'll conclude. Now, by way of divination, sorry, please, I don't know why this is not. Sorry, please. Okay, so you can see it in presentation form now. So now, sometimes somebody will ask you divine jaundice. So jaundice is yellowish discoloration of the mucosa of the skin and the sclera. Again, jaundice, yellowish discoloration of the skin, mucosa, and then the sclera, because those are usually the parts that you can visibly evaluate or examine. So once you see yellow discoloration of any of those parts, you say that the patient has jaundice. I hope that is taken. Now, there's a particular level, because and what normally gives that color is bilirubin. Bilirubin, it is yellow in color. Now, there's a particular level of bilirubin that you begin to see it in the sclera, in the mucosa, and all of that. So we'll get to that. So now, there's so many causes. There's so many disorders that can give you jaundice. However, most jaundice are usually physiologic. That is, they are normal. Just normal thing that newborn baby has. We're going to talk about why they can be normal too. Now, it is very easily diagnosed. It's a clinical diagnosis. Sometimes you now use laboratory backup to confirm it, at least to be able to let you know the modality of treatment that you are going to use. So that is why sometimes we need laboratory confirmation. But still clinically, you can be able to assess. For instance, if the jaundice is only on the face, it gives you a rough estimate that this is the particular value it is. If it's up to the chest, up to the abdomen, up to the thigh, or up to the leg, all of those can tell you that, okay, this jaundice is a particular level. By the time you are seeing jaundice up to the leg, that is likely the most severe form, in which you may have to do a rescue intervention, which is usually exchange blood transfusion. So, and then now, like I said, most commonly you see jaundice in a child who is a newborn within the first week of life, and nearly 8 to 11% of newborns develop jaundice. I mean, they will have high level of bilirubin in their blood. Up to 10% of newborn babies will do that. So, and between 60 to 80% of healthy infants are expected to present with idiopathic neonatal jaundice. So, there are some of them that will even have jaundice that you can't really pinpoint. That is, out of this 8 to 11% of them who present with jaundice, up to 60 to 80% among them, you cannot really pinpoint what causes the jaundice. So like we have said, neonatal jaundice is a discoloration of the skin and the sclera, and that yellow color is due to bilirubin. So in neonates, the derma icterus, another the clinical language we use for jaundice is icterus. and most time you notice on the face. And when the bilirubin level rises, it proceeds to the body and then to the extremity. So it starts from the face, spread through the neck, chest, abdomen, thigh, leg. It's unlikely for you to see jaundice on the leg and you will not see it on the face. So it goes in what we call craniocaudal manner. So, and when jaundice is also resolving, it resolves from from down upward. So don't let them confuse you in the exam. So if the baby does not have jaundice on the face, it is clearer. Don't look for jaundice in the chest or in the abdomen because it will not be there. Now, if a patient has jaundice in the leg, you can be sure that there is jaundice on the face. So if it is coming, it comes from the head to the toe. If it is resolving, it resolves from the toes to the head. So the one on the face is usually the last to disappear. I hope you understand. Such that if you are seeing a patient who has jaundice and that patient still has jaundice in the eyes, you see the eyes. So if you check the rest of the body and there is no jaundice, you can reassure yourself and say, okay, there is really no problem. The jaundice is resolving. I hope that is clear. So let's proceed very quickly. Now, what are the sources of bilirubin? Up to 75% bilirubin is sourced from the hemoglobin. So now, remember, hemoglobin contains M and globin. So now, the hem is being broken down by hem oxygenase to give you biliverdin. Now, biliverdin is then converted to bilirubin by an enzyme called biliverdin reductase. So it produces hemoglobin. So now you can also get it from myoglobin, that is also from the muscle. You can also find it from M containing enzymes, about 20 to 25% of the cytochromes. Most of those cytochromes also contains iron, contains M components that can be broken down and then to give you bilirubin, and from all of these other ones. So also you get it from ineffective erythropoiesis. For instance, ineffective erythropoiesis means that red blood cells that is in the formation of becoming adult, mature red blood cells, and along the way something goes wrong. The M is not well incorporated into the globin, such that you now see the hem will have to be degraded. So remember, the hem will still undergo that degradation, M oxygenase to the biliverdin, and by biliverdin reductase to bilirubin, and then bilirubin is found in the blood. So all of these that you have seen are sources of bilirubin. So please take note of them because they are usually exam questions. So now, like we have said, 80% of, okay, I think I've talked about this, 80% of bilirubin from catabolism of red blood cells. So now, converted to bilirubin, then bilirubin now is being delivered to the liver. So, and while bilirubin is in the circulation, it is bound to albumin. So albumin bounded to bilirubin is the one that now carries bilirubin to the liver. So, and on getting to the liver, there is something, there is a transporter in the, at the entrance of the liver called ligandin Y. Ligandin Y is a Y protein, so that now accepts the bilirubin from albumin and take it into the cytosol of the liver. Sorry, please. So it takes into the cytosol of the liver cells, that is the hepatocyte. So it is in the hepatocyte that you now have the conjugating enzyme. The enzyme there is the UDP glucuronine transferase enzyme. That's uridyl diphosphoglucuronine transferase. So it's that enzyme that conjugates bilirubin. And the way it conjugates bilirubin is by adding glucuronic acid to bilirubin, such that when one molecule of glucuronic acid binds to bilirubin, it gives you monoglucuronic mono, and then if two bind, will give you di. So you have a mixture of all of those converted bilirubin. So what it does is that it converts bilirubin that is not soluble in serum to the one that is soluble, so that it can easily dissolve and be excreted by the body. So we are going to see that very quickly. So now, I think this information might be important to you. Now, the breakdown product of hemoglobin. Now, 1 gram of hemoglobin gives you 35 milligram of bilirubin. So I don't know whether this information will be needed by you, but just for you to know. So now, like we said, uptake and conjugation takes place in the liver. I've talked about ligandin Y that facilitates hepatic uptake. Facilitate hepatic uptake. Then I've talked about the uridine diphosphoglucuronic transferase, which catalyzes the conjugation with glucuronic acid. I've talked about that one too. And after the bilirubin has been conjugated, it is now excreted in bile, and then it is emptied into the GIT. I hope that is taken. So these are just brief thing that happens until the bilirubin. So when the bilirubin gets into the intestine, it is converted to stecobilin. So the stecobilin now is the one that gives the color of the feces, the orange to yellow color that it has. That is the stecobilin. Now, some part the conjugated bilirubin also can be absorbed into the system, and then it is excreted in urine as urobilinogen. That's as urobilinogen. So, yes, as urobilin. So that urobilin is sometimes what gives the color of the urine, like something that is light yellow. So that is that. Let me proceed to now. Unconjugated, okay, all of this is just the story I've told so far. So now let me read what is on the slide. It said unconjugated bilirubin is carried in blood, it is bound to albumin. Some of them are free in the serum. So now bilirubin conjugation is the biologically critical activity in which it converts water insoluble to water soluble bilirubin. These are all of the stories I've talked to you earlier. Then the activity of we are going to see the significance of this third point when as we go in the teaching, that the UDPGT enzyme, that's uridine diphosphoglucuronic glucuronyl transferase enzyme, the activity is very low. It's very low in the first few weeks of life. Like for instance, at birth, the activity of that enzyme, you're disturbing me. The activity of that enzyme is about 0.1%. So the activity of the enzyme is about 0.1% at birth of adult size, I mean, compared to adult activity. And by the time the child is getting to the first week of life, the activity has increased to about 1%. So all of this can make a child as jaundice, because we are going to talk about what eventually usually leads to the yellowish coloration of the body that we often see. Let me proceed because of time so that we can cover. Sorry. Now, etiology. Let's talk about what are those things that causes jaundice. What are those things that causes jaundice? Now, remember there are two major types of jaundice, or let me say yes, or two major types of hyperbilirubinemia. Bilirubinemia means bilirubin in urine. Hyperbilirubinemia means that the level of bilirubin in the blood is high. So now it could be non-conjugated hyperbilirubinemia or conjugated hyperbilirubinemia. So now for non-conjugated hyperbilirubinemia, we'll talk about what could be the possible cause. So the cause could be hemolytic or non-hemolytic cause. It could also be from inborn error of metabolism. Okay, so those are the things we'll talk about very briefly. Now, for the hemolytic cause can either be intrinsic or extrinsic. So now, for those ones that are hemolytic and is intrinsic, this has to do with the red blood cell. Remember, we talk about the M. That is the M that has been oxidized by the M oxygenase to give you biliverdin. So now, as long as there is breakdown of red blood cells, so there will be issue with jaundice. So the intrinsic factor is if there are enzyme defects. Remember, one major enzyme in the red blood cell is the glucose 6-phosphate dehydrogenase enzyme. So when the level of that enzyme is low, so the patient can be predisposed to breaking down, because if you remember the role of G6PD enzyme in the glycolytic pathway, you remember that G6PD enzyme is the enzyme that helps to keep the NADP, that is nicotinamide adenosine diphosphate. It tends to keep them in the reduced state. It keeps them in the reduced state, such that when there is an oxidative stress, the reduced NADP will now bind to the oxygen. such that the stress can be, the stress that is being caused by those free oxygen radicals and the rest can be mopped up by glutathione. So now, but when GCSPD enzyme is deficient, the problem now is that the NADP cannot be kept in the reduced state. It remains in the oxidized state. So that when the patient is now subjected to an oxidative stress, what happens is that there is nothing to cushion the effect of oxidative stress. And then there will be hemolysis of that red blood cell. So that is why GCSPD deficiency, which is a deficiency of an enzyme, a major enzyme in the red blood cell that helps it to withstand oxidative stress. When that enzyme is deficient, the next thing is that the red blood cell can easily break down. And when the red blood cell breaks down, what are the components of red blood cell? It is hemoglobin and some other components. But hemoglobin is the major component of red blood cell. So now the hemoglobin contains hem and globin. It is a hem that is going to be oxidized to by M-oxygenase enzyme to give you biliverdin, and the biliverdin is now reduced to bilirubin by biliverdin reductase. I hope this is clear. Now that is that about GCSPD deficiency. Now another defect that is intrinsic to the red blood cell, that is as a result of problem with the red blood cell itself, is the membrane defect. It can be from membrane defects. So in which you have something like spherocytosis. So in which it's very easy, the red blood cell, instead of it to be concave, you know, if you remember the shape of red blood cell, it is concave, and that concavity gives you some advantage. But now the red blood cell is not concave, but rather it is spherical. So because it is spherical, it's easy for it to become deformed. And then once it's deformed, it will be quickly recognized by the spleen, and the spleen will take it and then break it down. And when the red blood cell is being broken down, it gives you M and globin, and then M is being metabolized to give you bilirubin. I hope this is clear too. Now, what are the other extrinsic hemolytic cause of jaundice? Examples, the commonest example in Nigeria and Africa generally is ABO incompatibility. So blood group incompatibility. Other ones include resource isoimmunization. Resource isoimmunization, yes, is rare, but usually very devastating in this part of the world. But it's very rare in Nigeria, it's very rare in Africa. But the commonest is ABO incompatibility. Please don't forget this when you sit in exam. You sit in exam and they ask you what is the commonest cause of hemolytic or non-conjugated hyperbilirubinemia. The commonest cause is ABO incompatibility. So sepsis, infections can also be an extrinsic cause of hemolytic non-conjugated hyperbilirubinemia. Now let's go to the non-hemolytic cause of non-conjugated hyperbilirubinemia. So non-hemolytic cause includes concealed blood from extravasated blood. What condition can you see? A baby who was born, who undergoes some stress while he's being born, and then is born with maybe cephalohematoma, subgaleal hemorrhage, or even frank intracranial hemorrhage. So now, as long as blood is being extravasated from the intravascular vessel into the interstitium, so now those blood that they will have to be mopped up by the cells of the body. So those blood will be broken down. As those blood that are not inside the cell, inside the intravascular volume have been broken down. So what happens is that they produce bilirubin, and when they produce bilirubin, there will be hyperbilirubinemia. So those are some extravasated blood so can also be from fracture. Sometimes they can have any of those fractures, humeral fracture, thigh fracture, in which there will be tearing of all of those vessels. All of that can give you hyperbilirubinemia. So sometimes, like an example of the intracranial bleeding we talk about, for preterm babies, their germinal matrix, that is the lining of their ventricles of the brain, the lateral ventricles, the lining are not very, very strong enough to help to secure the vessel. So the vessels area are very fragile, such that when those babies are not well taken care of, or they are shaken by a process we call shaken baby syndrome or malhandled, they can easily, those vessels can tear. And when those vessels tear, they will bleed into the brain. And when they bleed into the ventricles, the body will want to take care of that blood that is outside the intravascular space. In an attempt to take care of that blood, the next thing is that there will be production of bilirubin and hyperbilirubinemia. I hope this is clear. So another thing is polycythemia. Babies who are born with polycythemia, examples are those babies, especially infant of diabetic mother. Infant of diabetic mother, because there is a generalized excessive growth. They have hypertrophy, generalized hypertrophy, because of so much exposure to glucose while in the womb. So the bone marrow also can undergo hypercellularity, such that there will be hyperstimulation of erythropoiesis, in which there will be production of so much red blood cells, and by the time the baby is born, they have polycythemia. So now, when they have polycythemia, what happens? The body, that alone can stimulate hemolysis, but it is non-hemolytic. It's not an hemolytic process, so it is non-hemolytic. So, and when that happens, it will still give rise to hyperbilirubinemia. Other things is defective conjugation. If the bilirubin are not well conjugated, they are not properly conjugated, they might eventually go to the liver. Because of enzyme deficiency, they will go to the liver, and then when they go to they will not be properly conjugated. They will go back into the intestine, and from the intestine they will become reabsorbed back into the blood as non-conjugated bilirubin, and all of that can give rise to this. So other things are congenital enzyme deficiency, like we have in Gilbert syndrome and then Crigler-Najjar syndrome. Now in Crigler-Najjar syndrome, the major problem is deficiency of the main conjugating enzyme, the uridine diphosphoglucuronic transferase enzyme. There is a deficiency of that enzyme. So, and there is Crigler-Najjar syndrome type 1 and then type 2. Now, type 1 is the most severe. Type 1, there is total, complete deficiency of the enzyme, such that the patients are born, they cannot conjugate bilirubin. So they have difficulty, the battle with hyperbilirubinemia, and they can come down with the complication of it. The type 2 on its own, there's about 10% activity, of the conjugating enzyme, such that for them, when you give them phenobarbital serves as enzyme inducer, so it can help them to conjugate better. So now, let's go to other causes such as the inborn error of metabolism. Example is hypothyroidism. Now, the problem with hypothyroidism is that hypothyroidism is a state in which there is general slowness of the body. The baby, if you look at the baby who has hypothyroidism, they have a wizen facie. They'll be looking old, even though they are newborn. You see them, all their body is soft. They are very hypotonic. They can have protruded abdomen. The umbilical cord, they have umbilical hernia. So all of these, and then when they eat, their intestines also are very slow to move. So there is usually, because of that reduced evacuation of the intestinal content. So now it gives room for the bilirubin that is present in meconium. Meconium is the fecal matter that is inside the newborn baby. So it gives room for the bilirubin in the meconium to become reabsorbed into the system. And when they become reabsorbed, it increases the load of bilirubin that is in the plasma, so giving rise to hyperbilirubinemia. Now, intestinal obstruction, by the same process that we have talked about, intestinal obstruction, anything that prevents meconium from being passed. Meconium contains a very high level of bilirubin, and the bilirubin it contains is the non-conjugated bilirubin. It's an unconjugated bilirubin. So because of that, it's very easy for what we call enterohepatic circulation, that is from the intestine back to the liver. So that can cause hyperbilirubinemia. Now, another one is what we call the breast milk jaundice. Breast milk jaundice, if there are two definitions you must know very, very well that they can use to confuse you in exam, it is breast milk jaundice and breastfeeding jaundice. You must not confuse them. Now, breast milk jaundice on its own means that there are some content of breast milk. There are some things that are present in breast milk that can deconjugate the already conjugated bilirubin. For instance, bilirubin has gone through the liver, and when it has gone through the liver has conjugated it and excreted into the intestine. Now, while the bilirubin is inside the intestine, there is, as the baby now eats through the mouth, there is a content of the breast milk that goes into the intestine and deconjugates the already conjugated bilirubin. such that the conjugated bilirubin will now become non-conjugated, and any non-conjugated bilirubin can easily be reabsorbed into the system and then goes back to the liver. So breast milk jaundice can cause what we call increased enterohepatic circulation. So, and when that happens, there will be hyperbilirubinemia. The same way. Now, but the difference between it is this. Breast milk jaundice occur in a baby who is fully on breast milk, usually occur after the first week of life, usually after the first week of life. So, because by that time, the baby is feeding exclusively on breast milk. So, it is the content of breast milk that is causing the jaundice. Is that taken? So, now what do you do to treat breast milk jaundice? Some people say you don't do anything, it will resolve. If the level of the jaundice is too much, put the baby on phototherapy. While some say you can stop breastfeeding the baby for about 24 to 48 hours. While you give the baby breast milk substitute, then after 48 hours, you can recommence breastfeeding. You will notice that the level of the jaundice will drop drastically and never rise up to that point again. I hope that is clear. Somebody is talking. Okay, let me continue. So now the other one is breastfeeding jaundice. Breastfeeding jaundice, this one usually occur within the first week of life. Within the first week of life. And the reason for breastfeeding jaundice is because the mother has not established lactation, such that the baby is not taking in enough food. Because the baby is not taking enough food, there is what we call gut stasis. Gut stasis, because there is no food coming from up to push down the content of the intestine. So there is stasis of the gut. And because there is stasis of the gut, and inside the gut, we have meconium. And like I told you earlier, meconium has a very high concentration of bilirubin, I mean. Meconium has a very high concentration of bilirubin. So because of the delay in the passage of meconium from the intestine, it gives time for the unconjugated bilirubin in the meconium to become absorbed back into the system and gives hyperbilirubinemia. Even the one that is already conjugated in that meconium can become deconjugated by some gut bacteria, because some gut bacteria produces some particular enzyme that can deconjugate a conjugated bilirubin. So both in breastfeeding and breast milk jaundice, there is what we call increased enterohepatic circulation, but by different mechanism. In breast milk jaundice, which occur after 1 week of life, there is a content in the milk that causes that. While in breastfeeding jaundice, the baby is not taking enough. Because of that, there is gut stasis, and then there is increased enterohepatic circulation. I hope this is clear. So now, let me just go briefly through the causes of conjugated bilirubin. Now, in this one now, the problem is not with delivery of bilirubin to the liver. The problem is not with the liver. The liver has done its job. But now there is a problem now that is now making conjugated bilirubin to become accumulated in the blood. This one, I will just rush through it. Now, one of them is infection can cause. Whenever you notice that there is conjugated bilirubin, think of infection, sepsis. Also, touches infection is a very common cause. It could also be from metabolic causes, such as galactosemia, alpha-1 antitrypsin deficiency. Just take note of all of this for your MCQ sake. Johnson syndrome, Roto syndrome, all of this. Now, there could be an intrahepatic biliary atresia. For instance, now, after the hepatocyte has done what they needed to do, the problem now is that they cannot excrete into the canaliculi because there is atresia. So this will now accumulate in the liver, and then there is a backflow into the system. So it could also be from post-hepatic cause, such that everything has left the liver, but there is now extrahepatic biliary atresia. So the bilirubin, thank you. The bilirubin cannot pass through it. So also if there is a cyst that is causing an obstruction, such as colodoca cyst, that can do all of that. So we have talked about all of this earlier. There are different types of jaundice. We have the physiologic and then the pathologic jaundice. We also have jaundice that is due to breastfeeding or breast milk jaundice. So we want to talk about hemolytic jaundice. All of this we have talked about earlier. Now, let's narrow down on physiologic jaundice. Now, how do you say that this jaundice that you are seeing is physiologic? You should not say that, because physiologic jaundice is a diagnosis of exclusion. It's a diagnosis you make after you have excluded all the other causes of jaundice. Now, and sincerely speaking, it is, and scientifically speaking rather, it is the most common type of jaundice that we have. Most of them are physiologic. They will likely not cause no harm. So, what are those characteristics? Those things that can make you say, okay, likely this thing is physiologic jaundice. One, it usually occurs after 24 hours of life. Any jaundice that you see within the first 24 hours of life, it is not physiologic. So now, it usually peak. Physiologic jaundice usually peak around the 4th to the 5th day of life. That's when you see the highest level. So that is why when the baby comes by the 2nd day of life and you notice that the baby is jaundice, what to do is to determine the serum bilirubin. And then when you see the serum bilirubin, you can now follow it up by the 3rd, 4th day when you expect it to be at the peak, and see whether it peaks. If it does not peak, then you know that it's likely, if it does not go too high, you know that it's likely physiologic jaundice. So, and then physiologic jaundice disappear within 10 to 14 days of life. So by the 14th day, you should not see, if it's physiologic, you should not see it. So any jaundice you are seeing after 14 days of life is not physiologic jaundice. And most physiologic jaundice, they are usually unconjugated jaundice. So if it becomes conjugated, remember I told you, if it becomes conjugated, what it means is that it is pathologic. And you think of sepsis. Sepsis is a very common cause of pathologic jaundice, in which you see conjugated hyperbilirubinemia. I hope this is clear. So now, I will not talk about all of this. We have talked about it earlier. We've talked about all of this earlier. So now, why is jaundice significant? What makes it a significant entity that we have to even be discussing it? The reason is because it is toxic to the brain. It is toxic to the brain. Now, the jaundice that is toxic to the brain, it is the non-conjugated bilirubin, the conjugated one, but the unconjugated one. That is the one that is toxic to the brain. So, and the one that is toxic to the brain is the one that is plasma, not the one that is bound to albumin. The jaundice that is bound to albumin, it is not toxic to the brain because it will not enter into the brain. But the one that will cause toxicity is the one that is free, unbound to albumin. Okay, so now, most of the time, it is very difficult to measure that free albumin. So that is why it is sometimes you are not sure at what level, whether the one your machine is discovering is the one that is bound to albumin or the one that is free in plasma. So you cannot really tell. So, and then there is no absolute safe level of bilirubin, because it's been found that even in those who have very moderate level of hyperbilirubinemia, they still come down with complications. Why there are some that come with very severe form of hyperbilirubinemia, yet they did not come down with complications. So there is no agreeable safe level of bilirubin. So that is why it is very, very important to monitor those babies. So now, risk of toxicity is increased by factors that destabilize the bilirubin albumin binding. So anything that prevents bilirubin from binding to albumin can increase the risk of toxicity. And what an example of that? That is why there are some medication, there are some drugs that you don't give to a newborn baby, because those drugs, they have the capacity to displace albumin from the bilirubin binding site. They compete with bilirubin for albumin binding site. So example of those drugs is the cephalosporin, especially the ceftriaxone. We also have some drugs such as all of these sulfur containing drugs. They compete with bilirubin for albumin binding site. So, and any other, there are something that can alter the integrity of the blood-brain barrier, such as when a patient is acidotic, anybody who is having respiratory distress, having metabolic acidosis, all of that can cause hyperbilirubinemia and can increase their risk of toxicity to bilirubin. So now look at this baby. This is All right. Thank you, Dr. Isaac. Okay, so like I was saying, by the time you see that the level of the jaundice is about at the level of lower abdomen below the umbilicus, you know that at that level and up to the thigh, by that is already up to 200 millimole per liter. And once it's up to the nail, and the leg, but that's not going to the foot, the level is about 250 millimole per liter. But once you start seeing it in the feet, the level is above 250 millimole per liter, and it's already requiring exchange blood transfusion or intensive phototherapy, as the case may be. So let's talk about pathologic jaundice. Pathologic jaundice. Now, I hope you are taking note of all of this. One, any jaundice that appears within 24 hours of life is pathologic. Any jaundice that appears within the first 24 hours of life is pathologic. Now, if this level of serum bilirubin, if the rate of rise is greater than 5 milligrams per DL per day, it is pathologic. For instance, a baby, you notice jaundice on the second day of life and it was 5 milligrams per DL. And then you are noticing it by the third day of life, and the jaundice has become 10 milligrams per DL. You should know that you are dealing with pathologic jaundice, because the rate of rise per day should not be greater than 5 milligrams per DL per day. So should not be greater than 5 milligrams per DL per day. In addition to that, sometimes you may have to monitor the rate of rise over maybe 4 hours, over 6 hours. So it's also important to know the rate of rise per hour. So if the rate of rise is greater than 0.5 milligram per DL per hour, if the rate of rise is greater than 0.5 milligram per DL per hour, it is pathologic. I hope that is clear. Greater than 5 milligram per DL per day or greater than 5 milligram per DL per hour, it is pathologic. Now, if the peak levels are higher than expected for normal ranges, it is also pathologic. There is what we call a nomogram, in which when you get the value of the serum bilirubin, you will also get the age of the child in hours, and then you plot it against your graph. So when the level you get, when you plot, it is higher than what is expected for the age of that child, it is pathologic. Now, if the jaundice persists more than 14 days, it is pathologic. Also, if conjugated bilirubin is greater than 2 milligrams per DL at any given time, 2 milligrams per DL at any given at the conjugated fraction, it is pathologic. And also, if there are evidence of ongoing hemolysis, if you have evidence of ongoing hemolysis, it is also pathologic. And what are those evidence of ongoing hemolysis? When you see pallor, a patient who is jaundiced, you also see that the patient is pale, pallor. It's an evidence of ongoing hemolysis. When you do a blood count and then you see reticulocytosis on blood count, it is also pathologic. So you take note of all of this. Now look at a picture here that is showing a baby who is severely jaundiced. If you look, the baby is jaundiced to the leg. I don't know whether it is clear enough on your side there. So now, serum bilirubin is greater than 12 milligrams per DL in a term neonate, especially in the presence of risk factors, or greater than 10 to 40 milligrams per DL in a preterm neonate, is also pathologic. All of this defines pathologic jaundice. When serum bilirubin is greater than 12 milligrams per DL in a term neonate, or it is greater than 10 to 14 milligrams per DL in a preterm, because preterm neonates, they are more at risk of jaundice than a term baby. So the level can be higher in them than in a term baby. So it is pathology. So like I said earlier, jaundice that persists more than 14 days of life is also pathologic. And we'll talk about evidence of ongoing hemolysis, pallor, and all of that. They are also it's pathologic. So you don't say a child who is looking sick, a child who is having tachypnea, and because of that you say, let me send this patient home. The jaundice is not significant. The moment you see all of those risk factors, the patient requires attention and you need to treat. So now we've talked about breast milk jaundice, and then I think we can proceed from here. I've also talked about breastfeeding jaundice. So I've been able to differentiate it for you, breast milk and breastfeeding jaundice. So now, what are those investigations that you do in a patient who is jaundice? You do hemoglobin concentration or the packed cell volume, the PCV, with a blood group. You also do the what you call direct antiglobin test, also called the direct Combs test, because the one you do in the mother is the indirect Combs test. You do it in the mother. But when the baby is born, you take the baby's blood now, or you take cord blood and do the direct Combs test. You also estimate the serum albumin levels. You check peripheral blood film for red blood cell morphology that can give you, can make you to make diagnosis of substance like spherocytosis or all the epilocytosis, all those elliptocytosis, all those abnormal red blood cell morphology. We also check for the reticulocyte count. Remember I told you reticulocytosis, which is one of the features of ongoing hemolysis. You also do G6PD assay. So these are some of the investigations that you can do. You can do a liver function test to check the liver enzyme, to evaluate for any other abnormality. So there are quite a number of gamut of investigations that can be done depending on what you are looking for. But it's also good that I mentioned abdominal ultrasound scan, because it can also help with diagnosis or help to suggest the diagnosis of biliary atresia, which is also an important entity in the etiology of conjugated hyperbilirubinemia. So now the treatment of unconjugated bilirubin. The treatment of unconjugated bilirubin. So now you can see number one, we say observation and monitoring. It's not every baby that has jaundice that require treatment. If the level of the jaundice is not in the pathologic range, you may observe. While you're observing, you can monitor. So, and I've told you, you can monitor hourly, you can monitor over 6 hours, you can monitor over 12 hours, you can monitor daily. And then based on the knowledge you have had, that if the rate of rise is more than more than 5 milligrams per day, you can quickly intervene and say this one requires attention. Now, the second thing, you increase intake, fluid and oral intake. Remember I told you that reduced intake can exacerbate physiologic jaundice. It can make a patient to have hyperbilirubinemia because of increased enterohepatic circulation that result from gut stasis. So because of that, you encourage the mother to you support the mother to lactate so that the mother can breastfeed and the baby can start eating. The more the baby suckle and eats and take orally, the more the baby is able to excrete and pass meconium. And once the baby is able to excrete meconium, then the baby is no longer at risk of increased enterohepatic circulation. I hope you are following. Then the third modality of care is that you do phototherapy. So phototherapy, all of this, there's a threshold of phototherapy. Like I told you, there's a nomogram in which you plot, and then that nomogram will tell you, okay, this is the treatment that is required. Observe, monitor, or do phototherapy, or do exchange blood transfusion, which is the fourth thing, exchange blood transfusion. So now there is also what they call pharmacology treatment, even though the place of this one is not that established in clinical practice. Like I told you, type 2 Klinger-Naja syndrome can be induced such that when you give phenobarbital, the enzyme function can be induced. So in type 2 Klinger-Naja syndrome, and then the jaundice will improve. So you can also give intravenous immunoglobulins, especially in those ones that are hemolytic, that are autoimmune causes like ABO incompatibility, resource isoimmunization. The immunoglobulin will help up to mop up all those antibodies that are in the serum. So then we also have the metalloporphyrins. So these ones now, they help to mobilize whatever is in the blood. That metalloporphyrin, they help to mobilize those M that are generated through ineffective erythropoiesis. It helps to mop them up so that they will not have to go through that metabolic process that results in bilirubin production. So that is how it works. Now, there is antibiotics. You can give antibiotics when you suspect infection, and then you can give other supportive therapy. Now, we talk about reassurance and observation. So that's the first one. I think I've already talked about all of this. So you observe and monitor. Then pharmacotherapy, I've talked so. Okay, so now phototherapy currently is a primary mode of treatment especially in our environment too, and I think worldwide too, because even the fourth level of treatment, which is exchange blood transfusion, is no longer done in developed countries because they have very more advanced phototherapy machine that does not make them to do exchange blood transfusion any longer. But we still do exchange blood transfusion here, but it is not usually the starting point. When the baby come and then we have made diagnosis of hyperbilirubinemia, the first thing we do is to start phototherapy. Now the question is, how does phototherapy works? Now it works by three major processes: the photooxidative process, the configurational isomerization, and then the structural isomerization. I don't think I need to bug you with all of these details because it may likely be beyond you. When you finish your job and you write your primaries, you can come over for residency and then you will get more of these details. But remember, those three processes, photooxidation, configurational, it's majorly two: photooxidation and photoisomerization. Then the photoisomerization is now divided into configurational isomerization and structural isomerization. So the essence of all of this is that bilirubin is being converted to the form that can be easily excreted in urine. So that is the summary of how phototherapy works. Now, there's something we call intensive phototherapy. Intensive phototherapy. Now, intensive phototherapy is a form of phototherapy in which you deliver a high irradiance of phototherapy, so that it can help to do all those conversions, photooxidations, and photoisomerization very, very effectively and very, very quickly. Now, when we're talking about phototherapy, we talk about one, the wavelength, the irradiance, the distance between the baby and the light source, the surface area that is exposed to the light, and then the nature and the character of the light. Now, you need to understand all of this very, very well because they are exam questions, actually. They are exam questions. One, wavelength. The wavelength in which bilirubin is much more absorbed from the skin is the wavelength between 450 and 460 nanometer. In your exam, you can see up to 490. It is still acceptable. So, but it's between 450 to 460 nanometer. That is the wavelength in which the bilirubin is maximally absorbed from the skin. That is one. Then another one is the irradiance. Irradiance is the amount of power of the light that is being delivered on the skin. So, and then for intensive phototherapy, the irradiance is above 30 microwatt per centimeter square per nanometer. Greater than 30 microwatt per centimeter square per nanometer. Please, when you see this in MCQ, don't get yourself confused. Any value that is less than 30 is not intensive phototherapy. I hope that is taken. But any value above 30 is intensive phototherapy. 30 and above is very, very effective. So another one is the distance between the infant and the light source. So the distance should not be more than 50 centimeters. I mean, from the light source to where the baby is. The distance should not be more than 50 centimeters. Once it's more than that, it is no longer intensive phototherapy. It's ideal to keep the distance between 10 to 20 centimeters. You also do not want it to be so close so that the baby will not undergo what they call thermal bond. Although that is becoming a very rare occurrence now, because what we now use is a LED, light emitted diode. That's what is being used, LED bulb are what is being used, and they generate very minimal amount of heat. So they are not usually very harmful. So the distance should be between 10 to 20 centimeters, but should not be more than 50 centimeters. So another one is the surface area. Now, the more the surface area that is exposed to the light, the more the effectiveness. So that is why whenever we want to put a baby on phototherapy, the only thing we cover is we cover the eyes and we cover the gonads, we cover the perineal area. So because there are some studies that have shown that it could cause maybe some testicular issues or cause some issue with the eyes. So we just cover those to prevent any of those damage. While you expose the remaining part of the body, every other part of the body has to be exposed. And the baby should be regularly torn so that the part that the baby is sleeping on can also be exposed to light. Now, there is now different type of phototherapy machine. There's what they call a bilirubin bed, such that the light is being supplied from up, from both sides, and from under. So every part of the body is being exposed to the light. Now, there is also something we call the fiber optic fiber optic materials in which the baby is wrapped. The baby is wrapped around, like all the baby's part of the body is wrapped around, and the machine is now connected to power supply. And when it's connected to power supply, every part of the baby, apart from the gonad and the eyes, is exposed to phototherapy light. That is also very, very efficient. So, and then with that one, you'll be able to get better results with your phototherapy care. So now another one is the nature and character of the light source. So now the blue-green light is the most effective. The blue-green. The white light is also good, but it's not as effective as the blue and the green colored light. So that's why most time we use the blue. It's been said that the green is the most effective, but we don't use it in clinical practice because we've noticed that when babies are placed under green light, they look like cadaver. I hope you know what cadaver is, dead body. They look like a cadaver. So the sight is not so good. So that is why, but we would consider that their color is better when they are placed under blue light. So that's why once you see, in most centers, you see us using blue light. So now, what is the indication for phototherapy? When the patient has moderate to severe bilirubin, it's also used as prophylaxis in term. There's also something we call prophylactic phototherapy, especially in preterm babies. When you see a preterm baby and you know that this baby is at risk of having jaundice, you can start phototherapy so that as the jaundice is developing, the phototherapy can take care of it. It can also be used as prevention of post-exchange blood transfusion rebound hyperbilirubinemia, because during exchange blood transfusion, you bring out blood that is jaundiced and return a fresh blood to it. So, but after some hours, there will be equilibration such that you now see there could be a rebound hyperbilirubinemia. But when after ABT, we return the baby back to the phototherapy such that any other bilirubin that is coming up, the phototherapy can mop it off. So, I think we've talked about all these other. Now, what are the side effects? What are the side effects of phototherapy? Increased fluid loss. They can because the what is it called? The bilirubin is being excreted in feces, so there is increased fluid loss. Remember, I told you that the phototherapy works by converting the non-soluble to the soluble type. So the non-soluble to the soluble type that is being converted to now. Sorry, please, I have some distractions around. That's why. So sorry, please. Okay, sorry, please. So I was talking about the non-soluble to the soluble type. That is how those process of photooxidation. Okay, please, sorry for that interruption. So, like I was saying, the phototherapy helps to convert bilirubin from the non-soluble to the soluble. So the soluble one, when it becomes soluble, for them to be excreted in the urine and in the stool, they have to get fluid along, and the fluid they are getting along is being lost in the intestine, through the intestine, through the anus. So because of that, there could be dehydration. So it's one of the side effects. Now there could be retinal damage. That is why we always cover the eyes, like I said. Also, it's been postulated that it can cause damage to the gonads in males. That's why we also cover the perineum. Also, erythema of the skin. There could be some dermatitis, what we call photodermatitis. So it's not usually caused by the light itself, but you know the light attracts insects. So those insects that the light attracts can bite the baby and give erythema of the skin, and that one is transient. Once you remove the baby from phototherapy, all of that clears. There's also what you call bronze baby syndrome. So this one usually occur when you did not notice that the hyperbilirubinemia the baby has is conjugated and not unconjugated. Remember, I told you we use phototherapy for unconjugated bilirubin, not conjugated. So when you start using phototherapy for non-conjugal, and the mother will not be happy with you. Sorry, please. So now the next is exchange blood transfusion. Now, when is exchange blood transfusion indicated? One, when there is severe hyperbilirubinemia with total serum bilirubin that is greater than 20 milligrams per DL, which is equivalent to 340 micromole per liter. Once you see this, it is an indication for exchange blood transfusion. Now, if there is high rate of rise of bilirubin, like I told you, if the rate of rise in a day is more than 5 milligrams per DL, that is exchange blood transfusion. Or if the rate of rise is greater than 1 milligram per DL per hour. Remember, I told you that it is pathologic when the rate is greater than 0.5 milligram per DL per hour. So it is pathologic. You will be on the alert. But if you now see that the rate of rise is actually greater than 1 milligram per DL per hour, you don't wait for 24 hours. Rather, you quickly intervene with your exchange blood transfusion. Now, if the level of albumin is low, when you do a liver function test and you see that albumin level is low, you know that that patient will require exchange blood transfusion. Then, if there is concomitant anemia, the baby has anemia, so you should, rather than just give simple top-up blood transfusion, you should do exchange blood transfusion to help the patient better. Now, if there is evidence of danger signs that indicates that there's a compromise to the blood-brain barrier, maybe the patient is severely acidotic, but the level of the jaundice is not up to the EBT level. But you are seeing other signs that are danger signs that will tell you that this thing will continue to rise. So you quickly intervene by doing exchange blood transfusion. And what are those danger signs that you can see in the patient? Some family history of significant hemolysis. If in the family they have history of hemolytic disease that is confirmed, you may have to quickly do EBT for the patient. Now, if the onset of jaundice is in the first 24 hours of life, you can see that very fast. So you have to quickly intervene. And if there is signs of severe illness, like has been is listed here, you see patient is vomiting, lethargic, is not eating well, is all having high pitch cry, that can tell you that there's already complication setting. So you have to quickly do EBT. So, but for preterm babies, EBT are usually done at lower levels of total serum bilirubin. So now, note that agents that compete with bilirubin for albumin binding, acidosis will lead to high levels of free bilirubin, while hyperosmolality, hypercarbia, hypertension will impair the blood-brain barrier. I hope I've talked about all of this earlier, so please take note of this. Hyperosmolarity, hypercarbia, hypertension, all of this usually affect the blood-brain barrier, and they allow easy passage of the toxic unconjugated bilirubin to damage the brain. While things like acidosis or low albumin level, or when there is agents that compete for bilirubin binding site on albumin. So when you see that, those one makes albumin to now be free in the plasma, and it is the free albumin that is toxic to the brain. I hope that is clear. So indication for early EBT, I think we have talked about this. So let me proceed the procedure. I don't think I need to bug you with the procedure of exchange blood transfusion. So let's go to the complications. Now, complications can be from the blood transfusion, the blood you give, can be from the catheter placement while putting the umbilical vein catheter, could be a complication from the EBT itself, and then other ones. So the complication of blood transfusion, infections, what are those infections that can be transferred through blood? So whatever infection that you can think about, even though the sexually transmitted infections are no longer common because the blood are usually screened before they are given, like HIV, hepatitis B, hepatitis C, and then the syphilis. Those ones that they are usually not implicated because the blood are usually screened. But when the baby is given uncross-matched blood, those infections can be transmitted. Another infection that can be transmitted is malaria, because malaria is not one of the infection that is being screened. Another infection that can be transmitted is what they call cytomegalovirus infection, CMV infection, because most blood are not leuco reduced. So any blood that is not leuco reduced does not have leukocyte reduced component, so can transmit cytomegalovirus infection. So now another complication for the blood transfusion is the transfusion reactions. The patient can react to the blood if it is not well cross-matched. So now another complication is the complication of the catheter. Now there could be perforation of the umbilical vein. By the time, if the procedure is not well carried out, you may be too aggressive in putting the catheter, and then you perforate the vessel, and the vessel goes, and then the catheter goes into another component entirely, and then cause other damage. Wrong placement, if it's not properly placed, sometimes the vessel can undergo vasospasm such that it will not even be able to go through. So, and then can now, for instance, if you mistakenly put the catheter through the artery instead of the vein, there could be thrombosis, there could be ischemia. There could be ischemia of that particular area that is being supplied by that artery, and then will cause complication. So necrotizing enterocolitis is another complication. Necrotizing enterocolitis, especially because this splanchnic circulation, the vessels that supply the gut, they carry blood to the liver. Remember, so when they carry blood to the liver through the portal vein, so now part you are going to pass through is the ductus venosus that passes through the liver. So as you are removing the blood and pushing the blood, so there could be ischemia of those splanchnic vessels. And when there is ischemia of those splanchnic vessels, there can be gut ischemia. So gut ischemia, gut ischemia now can result to necrotizing enterocolitis. Okay, we have spent 1 hour, so let me be rounding up now. I think I'm almost done. I have just 6 slides to go. So complication of the EBT itself, hemodynamic changes that follow the push and pull process. So if you take the blood too much at the time, the patient can go into shock, hypovolemic shock. If you push the blood too much, too fast, the patient can go into hypervolemic complications in which the heart can undergo arrhythmia. There could be cardiac arrest from that. So hyperdynamic changes from the process. There could also be electrolyte changes such as hypocalemia. Remember, the blood you are removing a baby's blood that has enough calcium, and you are replacing with a blood that does not have calcium. Remember that for the blood to be prevented from coagulating inside the blood bag, they have to put anticoagulant. And the way what anticoagulant does is that they chelate calcium. They bind to calcium so that the calcium cannot stimulate coagulation process. So the blood you are giving does not have calcium. That is why it is said that for every 100 mils of blood that you exchange, you give 1 ml of calcium gluconate so that the patient does not go into hypocalcemic tetany. So another complication is hyperkalemia. How do they get hyperkalemia? If they are given blood that has hemolyzed, especially blood that has stayed so long in the blood bank and has undergone hemolysis. So when they have that type of, when you give the baby that type of blood, the baby can come down with hyperkalemia. And remember when we talk about hyperkalemia, I told you that hyperkalemia will stop the heart, will cause cardiac arrest at diastole. So that also is very, very important to note. Then other complications are the hypotemia, hypoglycemia. So morbidity and all of these I've talked about. Any of these can happen. They can have cardiac arrest and then pulmonary edema, respiratory distress, and all of that. Those are complications of exchange blood transfusion. So now for those babies who have surgical jaundice, in which there is either obstruction at any point, either bowel obstruction like intestinal obstruction or biliary atresia, they might require surgical consultation and they may have surgery. So complications of jaundice. Patient that has jaundice, especially very severe jaundice as a newborn, they can grow up later to become an autistic patient because of the damage to the brain, some part of the brain. So now they can also come down with frank cerebral palsy. There are some part of the brain that are affected by jaundice. We have the putamen, we have the globus pallidus, we have the hippocampus. So especially the affectation of the hippocampus can make them to have autism. It also affects the inferior olifary nucleus, the superior colliculus, the oculomotor nucleus, the vestibular nuclei. So all of these are what is affected by jaundice. And then they can also have mental retardation. Other complications they can also have what you call dental hyperplasia. You see, no, hypoplasia, hypoplastic dentitious, or you see that their teeth are colored green, colored green or colored yellow. So that's where their teeth appears. So they can also have what they call sensorineural deafness. They can be deaf. So, and then they can come down with cerebral palsy, like we have said. And the type of cerebral palsy they come down with is what they call the chorioathetoid form of cerebral palsy. Chorioathetoid, you just see them, they will be shaking their head like this, like in a rhythmic form, the way their body, everybody will be, everything will be moving like this. They can have chorioathetoid form of cerebral palsy. And for some of them, even as a neonate, they can just die. And that is one of the most feared complications of neonatal jaundice. So, in conclusion, jaundice still contributes significantly to neonatal mortality and long-term handicap in our sub-region. So education is very important, both to health workers and the public, especially at the antenatal clinic. There's no case of clinical jaundice that should be dismissed without investigations. I emphasize this during the teaching. Early discharges should be well advised about jaundice. When you are discharging a mother within 24 hours, you should let the mother know that the baby has to be brought back by the second or the third or the fourth day of life for evaluation for jaundice. So glucose water is not a treatment for neonatal jaundice. Breastfeeding really causes severe jaundice. So it's good that the baby starts breastfeeding on time. So any discharge before 48 hours of life should be evaluated again the next 48 hours for breastfeeding insufficiency and development of jaundice. Remember, I told you when the baby does not start sucking on time, there could be issue with breastfeeding. Sorry, when the baby is not, there could be issue with jaundice when the baby is not feeding on time. So mothers who are being discharged from the hospital should be supported to breastfeed their baby. If they're having challenges with breastfeeding, they should be helped. And then if we notice that it is jaundice, we can now help them. So for further reading, I use the nursing textbook of pediatrics. I use the 21st edition, sorry please. Then some information from Medscape and then from our update. So thank you very much for your attention. I'm open now to answer questions. So let me know if you have any question.
No, sir. Thank you very much, sir.
All right. So in the absence of any question, so I can call it a day. So I assume that we understood everything that we have discussed.